Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup Compliance Webinar Series. Today's topic is 2026 Medicare Physician Fee Schedule Proposed Rule, Part 1. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. With that, I'd like to introduce our presenters, Martie Ross, Lori Foley, and Sarah Bowman.
Thank you, Jennifer. Good morning, everyone. Thank you for joining us. I am very pleased to be joined by my colleagues in PYA's Revenue and Compliance Integrity team, Lori Foley and Sarah Bowman. And we're going to spend the next hour with you discussing provisions in the 2026 Medicare Physician Fee Schedule proposed rule. The proposed rule was published on July 16, and comments are due to CMS on the proposed rule by September 12. Sarah would remind you that's her son's birthday, so she's looking forward to that date. You see on the screen the link to the proposed rule in the Federal Register, and we've copied onto this screen directions on how to submit a comment, and it's extremely easy. As you see that green button, Submit a Public Comment. When you click on that button, you will see the screen that is then on the right-hand side, and you simply start typing and including your comment, or you can alternatively attach a document. You can submit comments anonymously if you wish to do so, but we encourage everyone to make sure your voice is heard, relying on professional associations to submit your comments is fine, but appreciate that these rules impact folks differently. And it's important for CMS to hear how they impact you before they become the rules of the road that we all have to follow. But today we're going to discuss about half of the rule. Actually, if we were doing the page numbers, this is about 3/4 of the rule, because as Lori will tell you, the MIPS section takes up page after page after page in its detailed discussion of the different measures. But we're going to cover the conversion factor, the efficiency adjustment, the practice expense methodology changes, and then, as I referenced, the MIPS program, the new mandatory alternative payment model, the Ambulatory Specialty Model, and then wrap up with the Medicare Shared Savings Program. 2 weeks from today, we will cover the rest of the rule, as you see there on the right-hand side of your screen. So without further ado, let's talk money, which is always the first place I go when the rule is published, to look at what we're doing with the conversion factor. And how this process works was determined by a piece of legislation passed back in 2015, 10 years ago now, MACRA, the Medicare Access and Chip Reauthorization Act of 2015. It was a bipartisan piece of legislation passed by overwhelming majorities because it was intended to correct the bane of our existence at the time, the sustainable growth rate, the formula that had previously been put into effect about a decade earlier, which tied Medicare payments under the fee schedule to gross domestic product. And after a period of time, you had Congress having to intervene on a regular basis to what we call the doc fix, to increase the amount of the payments accordingly. MACRA replaced the SGR with specified annual payment increases, you see there on the screen, which meant it was how much we were growing the pie of money available to make payments under the Medicare Physician Fee Schedule, so that would go up each year accordingly. MACRA also created the Quality Payment Program, which gave us the MIPS program, as well as qualifying alternative payment models. How we calculate fee schedule payments is critical to understanding how we get to the conversion factor and then appreciating how different strings that CMS pulls in the proposed rule have an impact on providers differently, depending on their specialty, depending on where they practice, depending on the types of services that they provide. So for each service that is reimbursed on the fee schedule, it is assigned relative value units. There is specifically 3 types of relative value units: the work RVU, which is the practitioner effort involved in the service; the practice expense RVU, which is how much it costs to produce that service, other than the professional services furnished by the practitioner. And then there's also a component for malpractice expense, relatively small RVUs, but those cover the expense of securing malpractice coverage for that practitioner. We determine fee schedule payments by multiplying the services assigned RVUs by a conversion factor. And that gives us the national payment rate for that specific service. So what we care about is what's that conversion factor. And that dollar amount is set based on that statutory cap on Medicare physician fee schedule payments. Remember, MACRA adjusts that pie size each year. The conversion factor is simply, once you take all the anticipated RVUs that practitioners will produce in the next year, the conversion factor is then the amount assigned to each RVU. And so it multiplies out. Beginning in 2026, for the first time under MACRA, we're actually going to have 2 conversion factors. We're going to have a qualifying APM conversion factor and a non-qualifying APM conversion factor. So if you are a practitioner that is a qualifying APM participant, your conversion factor will have gone up more significantly than a practitioner who is not a qualifying APM. Appreciate that there is no inflation adjustment in the Medicare physician fee schedule. All other prospective payment systems in Medicare acknowledge the impact of inflation on the delivery of services. The fee schedule does not. It instead is tied to that MACRA determined amount of dollars available for payments under the fee schedule. We're not done, though, because there's another piece to this puzzle that becomes critically important, which is the budget neutrality requirement in the Social Security Act, which directs CMS that if it makes changes in the RVUs, so if it expands coverage or it increases the RVUs assigned to a particular service, if the impact of those changes would result in more than a $20 million impact, CMS then has to adjust the conversion factor to account for that change. And so if we increase the covered services or increase the RVUs assigned to the existing services, we have to thin out the conversion factor so that we slice the pie accordingly. Or if we reduce coverage or reduce RVUs, we can expand out the conversion factor because there's more dollars available. It has been a rough 5 years, as you well know, under the Medicare physician fee schedule.
We didn't get that stability we were hoping for, Martie.
Not exactly. But we have gone down by 7.3%. The fee schedule has been reduced by $2.54. And that's after Congress has stepped in and increased the fee schedule following CMS finalizing the Medicare physician fee schedule. But if you think back, this is not what MACRA said. MACRA said we'd see a 0%. It would even out during the same time period. The issue, of course, is that budget neutrality, because what CMS had done over these 5 years was adjust RVUs and expand coverage. Particularly there in 2021, where you saw that projected 10% reduction in the final rule. That was because that was when we were expanding the RVUs assigned to E&M services. And so that's how we were accounting for that, was that reducing payments by reducing the conversion factor. So this is really the story of budget neutrality as opposed to the story of the MACRA dictated size of the pie available to pay physician fee schedules. And of course, as you see, we have not anywhere come near keeping up with inflation. So when we talk about the hospital proposed rule, the inpatient rule, the SNF rule, whatever those may be, we're always talking about an increase in the base rate, which is based on inflation. We don't have that in the physician fee schedule payment. Sorry about that. Next slide. So let's talk finally about what are we going to see in 2026. We start with the 2025 conversion factor, $32.35. We apply the MACRA update. Again, that's where we now get 2 conversion factors. Then we go to the One Big Beautiful Bill Act, the OBBA, which provided for a one-time increase in the Medicare physician fee schedule payment amount by 2.5%. So for 2026, Congress has stepped in and says, we'll kick up the size of the pie by 2.5%. And so you see how that impacts the conversion factors. And then finally, we have a positive budget neutrality adjustment of about 0.5%. And so that gets us to our final rates, the 2 final rates for 2026. If you are a qualifying APM, it's about a $1.24 increase. If you are non-qualifying, it's about a $1.07 increase over 2025. Let's talk specifically about this positive budget neutrality adjustment, which looks great news. It's 0.5% more than we were expecting, but appreciate this creates winners and losers because it means we've shrunk the number of RVUs, we've decreased coverage, or we've decreased the payment assigned to specific services. Again, by 0.55% this year. Last year, we had the itsy bitsy positive adjustment of 0.5%. But as you see in the prior years in 24 and 23, we had much more significant negative adjustments, again, tied to the fact we were expanding coverage or increasing payment. For 2026, the drivers of this positive budget neutrality adjustment are first the efficiency adjustment to work RVUs, which Sarah will explain to us, for specifically non-time-based services. So we've shrunk the RVUs for certain types of services. We have an increase in behavioral health payments, which is the third year of 3 increases, specifically for payments for clinical psychologists and social workers. So you'll see their payments go up significantly. We've got revaluation of specific codes through CMS annual review of code valuations. And finally, some supply and equipment updates. All of that contributes to less spending and thus a higher conversion factor. And specifically, as CMS analyzes the overall impact of the positive budget neutrality adjustment, they see that almost all specialties will either see a 1% decrease in their allowed charges up to a 1% increase in allowed charges. There's some outliers. If it's not great to be a radiologist or an interventional radiologist. It seems we say that about every year, isn't it, ladies? Because they'll see about a 2% decrease. But as I've referenced previously, clinical psychologists and social workers are seeing about a 3 to 4% increase across the board. Finally, I want to make note of geographic practice cost indices, or GPCI, as we like to refer to this particular acronym. This is how we take the national payment rate and adjust it to account for cost variations across 108 localities throughout the United States. Every state has at least one locality, but I think California has like 24. It's just recognized variations in costs throughout the nation. The average is 1.0, that's the national payment rate, but we make 3 separate adjustments, one for physician work, which is based on what's the average salary for individuals with higher education in that particular locality. One for practice expense that accounts for employee compensation, office rent, purchase services and equipment and supplies. And again, one for the malpractice RVU. So we don't make one single adjustment to the total RVUs. We adjust all 3 RVUs that contribute to each service. CMS this year, as it does every 3 years, is updating the data on which these adjustments are based, and then it'll phase those adjustments in over 2 years. So 26, 27, 28 will stay steady, and then in 29 we'll do it all over again and adjust these data points. CMS decided to continue using the same data points as it had previously, just using updated numbers, although it did say that they've got some pretty serious concerns about the data on which they rely for practice expense. Oh, we'll hear that theme again, won't we, Sarah? So they're warning us of some future rulemaking in that particular area. But what I want you to underline, highlight, mark in red pen is that last bullet point. Because this year, in calculating the gypsies, CMS did not include the 1.0 floor to the work gypsy. What does that mean? For years and years and years, Congress has routinely approved a base adjustment on work RVUs, saying, and it doesn't make sense, right? Because if one is the average, there are certainly going to be localities where the work RVUs are lower. I mean, excuse me, the work expense is lower, but we've artificially raised everyone up to 1. And over time, that's if you're one of those, I think there are 46 localities that, in fact, their gypsy would be calculated as being below 1. They've always been increased up to 1. Well, as it stands today, that temporary adjustment, which of course has been approved every single year, is set to expire on September 30. As are, telehealth flexibilities and the like, because Congress only extended the gypsy work RVU base for that period of time at the end of this fiscal year. So absent congressional action, if you were in one of those 46 localities, you're going to have a decrease in your payments because your gypsy will be lower. And the percentage multiplier across the national payment rate will be lower. So here's something to comment on, or more importantly, to make sure that your legislative delegation is aware of this, is that if this is not renewed by Congress, beginning for fiscal year 2026, those practitioners in your service area will be negatively affected. So on that great piece of news, I am going to hand this over to Sarah to talk about the efficiency adjustment and the practice expense adjustment, two of the many surprises we found in the fee schedule when we opened it up this year.
More great news, Martie. You're sending it to me for more great news. So thank you. Martie, you talked about the conversion factor and that kind of 5-year trend of what we have seen over time. These next two items that we will talk about will still impact at the end of the day that total calculated Medicare allowable amount. So your total estimated calculated payment for a service. But instead of getting at the conversion factor piece of the equation, we're talking now about the RVU piece of that equation. So the efficiency adjustment is brand new for 2026 and a surprise for us all. Historically, when looking at setting of work RVUs and practice expense RVUs, there has been an important survey that has been done by the AMA RUC Committee, the formerly known Relative Value Scale Update Committee, informally known as the RUC Committee. And this group surveys providers across specialties, across specialty societies to understand what it takes to do any service that's paid by Medicare. So they collect data from providers on the pre, intra, and post service time components. So if you think about a procedural service, think about a gallbladder removal. You're going to have work that's done prior to the procedure. The intra-service time is the time on the table, so to speak, where the patient is actually getting the procedure done. And then that post-operative time, immediate post-op care, following in the hospital if the patient needed to be hospitalized afterward, follow-up visits that may happen in the office at the end of the service. So those service time components. Now, we have known for years that the RUC survey data is imperfect, but it is the best sort of data point that we have of its kind to rely upon. Over time, some of those imperfections have perhaps become more significant. We're seeing, lower rates of respondents, some variability in the data that we're getting from that survey. It's kind of like when my son and I argue over how long it takes to unload the dishwasher. I can do it really quickly. I've actually timed this, so I know exactly how many minutes it takes to unload the dishwasher. It takes him longer. Some would say that's because I have way more experience than he does. I would argue it's because he watches YouTube on his phone while he tries to unload it. So this makes it take a lot longer. But those same kind of flaws and that bias still obviously exists if you are a physician that is responding to the RUC survey. So you may be less experienced. The procedure may take you longer than a colleague that's been doing gallbladder removal surgeries for 30 years, for example. But we are seeing, and there have been studies done that kind of pressure test that those time estimates that are in the RUC survey are overstated. And so there has been, concern and talk about this for years in terms of the way that we're using that information and relying upon it. There is also concern from CMS as to, okay, if we have this low group of respondents, we've got some that do respond and we have others that don't. And what is different about the folks that do respond versus those that don't? And is that another layer of perhaps inconsistency that's sort of making the results of that less accurate? So this efficiency adjustment is proposing to sort of counteract that overstated value that we have been relying upon. This is a reduction to the intra-service time in the calculation that would be applied to the work RVUs. So it would apply to the work RVU component of the total RVUs. It would result in a new work RVU value. It would be applied for non-time-based services. So any CPT code that is being billed essentially, or can be billed based on time. So think about all of your E&M services, your care management services. You've got a lot of behavioral health and telehealth services in there. None of those would be included in this efficiency adjustment. There's also currently in the proposed rule a carve out for maternity care, taking into account that your global delivery OB package really encompasses almost a year's worth of services. So they're not adjusting those at this time for the efficiency adjustment factor. But really, even when you take all of those services that are time-based out, you're looking at almost 9,000 CPT codes. You're looking at over 8,000 CPT codes. So it's going to, as proposed, will be applying to a lot of services. So the methodology that CMS is proposing is to look at the Medicare Economic Index productivity adjustment percentage. So the MEI is a measure of practice cost inflation. It's looking at essentially your metrics of cost within the practice, your rent, your equipment that you have within your practice, non-physician employee compensation, so your other providers that you have within the practice. It's a measure on that inflation amount. It's looking at the past 5 years. It's adding those numbers up and getting to a 2.5% decrease. So that 2.5% decrease would then be applied to the intra-service time, and that translates to a reduction in the work RVUs. Now, if they're moving away from the RUC survey data that we have relied upon for so long, then the next question is, what are we going to be using going forward, right? And so going forward, CMS has said, we want to get past this kind of inherent respondent bias, if you will, these low response rates and things. We want to get data that is valid, that's reliable. We want to get some empiric data collection. And in the proposed rule, they specifically note electronic health record logs, operating room logs, and time motion data. Those are 3 specific examples that they give as to how they might collect better, more reliable, more accurate information as to what it takes to do, to provide these services. And so over time, they are expecting that these efficiency adjustments combined with changing the survey data, if you will, to this data collection process will yield more accurate valuation of services under the Medicare physician fee schedule. So as proposed, this adjustment would begin in 2026 with a 2.5% reduction that we spoke about. And then you'd have additional adjustments every 3 years. So when we fast forward into the future, we would be back at this again for calendar year 2029 rulemaking. So
Sarah,
big changes there.
And I was just going to add, we've got new programs, we've got new rules, we've got these areas with comments. When you're looking at that part in particular, each time we have those rule changes or we have those new programs, we have to have new operations, we have to have new financial setup, we have to have all these trickle-down effects. And so back to your original point, Martie, about the importance of comments, just thinking logistically of those EHR logs, those operating room logs, those time motion data, we get those for some of our consulting projects, and they're hard to get from our clients in a usable form. So trying to get it in something that's usable, that you can pull out, that you can submit and would want to rely on and submit to Medicare, it's a big deal. It's a little line, but it's a big deal.
Yeah, and even if we think about, providers, health systems' ability to do this, practices' ability to pull some of this information together, it's going to be heavily dependent upon what systems do they use, right? What version are they on? When was their last update, upgrade, all of those things. And so, we joke sometimes, a client that's on Cerner or a client that's on Epic, you could have 10 of them in a room. It could be a completely different install, completely different choices, completely different reporting capabilities. And so it really will be a situation of the devil's in the details as to how that collection process ultimately works. So this is a good time to make a little note, submit one of those comments like Martie showed. It's very easy, and make sure that CMS knows what this is going to mean for you, for your organization. And if you have ideas as to how to do this better, definitely now is the time. Please do speak up. So another good news, I drew the short straw, I think, on all the good news that I get to share today, unfortunately. So we talked about impact to the work RVU component of that kind of Venn diagram that Martie showed earlier. Now we're going to talk about impacts to the practice expense component. And so today, reimbursement under the Medicare physician fee schedule is for a lot of services, not all, but a lot of services, there is a site of service differential. So if you are doing the service in your office, place of service 11, it's paid under a non-facility rate for the Medicare physician fee schedule rate. That is generally higher because of the practice expense component of the service being higher to cover the overhead associated with operating the practice and providing that service than if the same service were done in a facility setting, in a hospital setting, if you will. Because it's understood that overhead is then captured by the facility claim, facility billing component of that under the outpatient prospective payment system. There are some indirect practice expense values, I'll say, baked in to that facility reimbursement rate as it stands today. The thought there being that there are still some costs associated with rendering that service and running the practice. And because in the beginning of time, when most physicians had a private practice and then also saw patients in the hospital setting, there was sort of some credit given to that practice landscape at the time. Fast forward to now, and things have changed. A lot of physicians are employed, have some sort of an employment relationship with health systems. The number of physicians in private practice has declined. And so this current methodology is thought to be somewhat skewed, somewhat out of date, if you will, from a CMS standpoint. So the current methodology relies on AMA's survey data. It relies on their physician practice information survey data, or PPI, and it measures specialty-specific practice costs. It's old. It's an old survey. It's old information. They've attempted to revise it and revamp it. They've rerun it. They did additional survey efforts last year in 2024, submitted those to CMS, but CMS felt like, based on a number of limitations, we want to scrap that. We don't want to use that survey data for our 2026 rulemaking. We want to change that methodology because it's not taking into account that shift in physician employment status. And there are a number of reports out there, some of which are old, some of which date back 10 years. The RAN has done a study on this. MedPAC has been talking about this for quite some time. So there are MedPAC reports out there that talk about site of service differential. It's interesting because this is sort of a more direct hint at CMS's push for site neutrality, site neutral adjustments. We've seen that already under ops. We really haven't seen a whole lot of this as it relates to the physician's professional reimbursement under the Medicare physician fee schedule. So this is a new adjustment in that way. And essentially, it is proposing to recognize greater indirect costs associated with running a practice for office-based services versus those being conducted in the facility setting. And if you're interested and really want to get into the nitty-gritty, the formulas and the calculations and the steps, I think there are 18 to 20 steps outlined in the proposed rule. I'm not going to go through all of them, but we are going to just kind of try to hit it at a high level here. So essentially, the survey previously relied upon, as I mentioned, kind of dated information, if you will. CMS is now proposing to rely on information that it feels is routinely updated hospital data to understand some of those cost assumptions for services that are technical in nature paid under the Medicare physician fee schedule. Their goal, and this is straight from the CMS's lips, so to speak, is to promote price transparency across settings, to offer more predictable rate setting outcomes, and to limit the influence of limited survey data. So we're kind of seeing a little bit of a theme here between the changes with the efficiency adjustment and then the changes here on the practice expense side. So this calculation, this adjustment, essentially will mean that facility services will have their practice expense RVUs adjusted. They will be allocated at half that of the non-facility amount for the same service. So what that means for all practical purposes is that when you have procedural-based specialties that are rendering a whole lot of services in the hospital setting, they're going to see a decrease in their practice expense component, which ties into total reimbursement for that professional service. Your office-based specialties and those that have a heavy reliance on time-based codes may see an increase. So your family practice providers, for example, psychiatry, geriatrics, those types of specialties may see an increase. So as Martie mentioned, we still have winners and losers. CMS has estimated that across almost all specialties, their words, that they will experience no more than plus or minus 1%. We can already do some sort of spot checking and testing and see that there still are going to be winners and losers. I appreciate that the plus or minus 1% math, but individual service impacts are absolutely going to vary. This is an excerpt from Table 92, which is in the proposed rule, which lists out what CMS is saying is the proposed impact by specialty. And you can see in total, family practice has got a combined impact of 3%. So they're seeing that increase that we talked about. They're saying that hematology oncology is going to be relatively flat, which is interesting to me because you'll see that the facility line there is a double-digit haircut. And then radiology, as Martie mentioned earlier, unfortunately for our radiology friends, you guys are getting hit again and seeing kind of a net estimated impact from CMS of 2%. When you get into some other surgical specialties, cardiology, GI, others, these numbers are likely going to look different. So it's a great idea to go ahead and start having some conversations and looking into this further, depending on where you fall from a specialty and provider mix standpoint.
Yeah, it's interesting, Sarah. CMS is very clear that this adjustment had no impact on budget neutrality because they say, well, at the end of the day, it's all even. We're just rearranging who receives how much money. Yeah, it's really significant. I mean, if you're oncology, if you're a facility-based oncologist, which very significant percentage are now, you're looking at 11% decrease. I mean, in your allowable charges, that's what Table 92 is. It's the allowable charges estimate. It's stunning.
Yeah.
Table 92 is one of those, back to what do you first go look at? You look for the conversion factor, you look for that Table 92, just to kind of understand where all the pushes and pulls are going to play out if it goes through as proposed. So, well, thank you, ladies. I'll carry on. Martie teed up merit and the merit-based incentive payment system, the MIPS program, quite well. It's interesting. It did take up a lot of space and a lot of pages in the proposed rule. The summary that was posted on the quality payment system website the QPP.gov website. The summary is 39 pages, and it's pretty concise the way that they organize it. So if you just need that quick reference, you have 40 pages to go look at over there. But it's introduced by CMS as, hey, we're only recommending limited changes this year. And so it's ironic, but I do think when you go in and kind of break it down, a lot of it is request for information related. And really what we see there is, their goal, they say their goal is to focus on stability. I think as we were looking through all these other changes and sunset of some of these programs and stuff, there was always the question is MIPS finally going to be cut? I don't think it's going to be cut. I don't see any indication that MIPS is going to go away. In fact, it continues to be a doubling down, if you will, of the transition. We've talked about that over the years. The transition from Medicare's been very clear. Their goal is to have providers get into an advanced payment model. And I think they continue to add the carrots out there to do that. The fallback was MIPS. They've added the MIPS value pathways, which we'll talk about a little bit. As far as the MIPS world goes, if you're not going to be in an APM, they really want you in an MVP, a MIPS value pathway. So that's where they're trying to stabilize kind of the program and continue to refine it in a manner that is not making a lot of changes that would at all detract providers' ability to eventually shift to an MVP or shift to an APM. They continue, I think it was in 2022, maybe. That's the only year that they put in the regulation that they put a target date out for a sunset year for traditional MIPS. That was 2027. Hasn't been stated that definitively again, but there are at least 8 to 10 references on traditional MIPS. If you just kind of do a word search in the proposed rule for traditional MIPS, referencing its intention to be sunset, that they were really wanting to do away with traditional MIPS. You're doing either MVP or you're doing the APM model or an ACO type of participation. And so it's interesting that they say it's, they're being very static. They're not making big sweeping changes, but it did consume a lot of information. They also say a lot of space in the rule to refine that statement. And they also say it's in response to feedback and information and input that they have gathered from interested parties, both providers and those supporting providers in the MIPS program. So again, I know if we say it once, we'll say it 50 times. Your comments matter. And this is one area where we do see that play out. So diving in high level to some of the areas, they are, it was in previous rulemaking. It was in last year's rule when we finalized data completeness at 75%. So for 25 and 26, we knew that the data completeness standard would be at 75%. In this proposed rule, they are planning to hold that steady. So no proposed changes. You might remember a couple of years ago, they surged to as high as 80% data completeness, but they seem to be stopping and holding that 75% static through performance year 2028. So that gives us some predictability, and I think that's what that affirms kind of what their intent was in not moving the needle too terribly much. There are 190 quality measures proposed for 2026. That includes the addition of 5 new measures, including 2 ECQMs. They are making substantive changes to 32 existing measures. But if you think back to prior years, that number was, I would say, in the 50s and 60s. So the fact that they're only making substantive changes to to that 32 is a lower number. They're removing 10 measures from the inventory, and most of those removals are due to measures which they say are extremely, extremely topped out. Some of them are where the measure steward, whoever was responsible for developing the measure, is no longer able to support the data or provide the information related to that measure. And then there are some that are just no longer best practice. And so they are sunsetting those measures to make sure that they are still incentivizing good quality contemporary care. The other thing that was included with Some of those removals are associated, and you'll see a couple of comments as we move forward where they are really aligning, they are making certain kind of across the board adjustments, and they're wanting it to align across all programs. So for example, removal of COVID related requirements, removal of social determinants of health types of items. So that theme runs into other programs, and they're trying to stay aligned for each of those programs. And then remember that the QCDR measures are not adjusted through this process. They are handled outside of rulemaking, so they're not included in this count. This is only related to regular quality measures. There are a number of topped out measures. A lot of them are in the measures specialty sets, and really focused in areas where there were limited choices. And a lot of times where that measure, because it is so topped out, there's not any additional measure development, and therefore it's limiting participation. So they're trying to call out those measures where they're not they might be getting a handful of participants, not a lot of participants. When we talk about MVPs, remember one of the goals there was to organize providers into buckets so they could do meaningful comparison across similar providers. And so if we have those strain measures out there where they're unable to do that, that's what they're beginning to remove. Those, starting last year, part of last year's rulemaking was that those would now be identified through rulemaking. So we do see 19 measures that are proposed to meet that topped out status, including 4 claims measures. If you are still reporting via claims, which some small groups are able to do, then that count goes down by 4. That makes that a little harder to find the measures that are still applicable, so something to be looking at. They are also looking to or proposing to revise the definition of high priority measure. Again, following you'll see those themes. It's to remove the health equity in particular from the definition, and you see on the slide the new definition as an outcome, including intermediate outcome and patient-reported outcome measures, appropriate use, patient safety, efficiency, patient experience, care coordination, or opioid quality measures. So trying to be very, very specific in certain areas as to what makes a measure a high priority measure. They are also proposing to make some changes for administrative claims-based quality measures. So recall, those are the measures that CMS is using your claims data in the background. You're not submitting any information proactively related to these quality measures. Those include activities such as, or measures such as the hospital-wide 30-day all-cause unplanned readmission measure, the risk standardized complication rate following total hip and total knee, some group risk standardizations based on hospital readmission rates, those types of measures. So they're proposing to really align that benchmarking methodology for cost measures, kind of aligning it with how they calculate the benchmarks for cost measures, beginning with performance year 2025, payment 2027. So remember, we always have a 2-year lag from the year of performance to the year of payment. I highlight it though, because this is one of those where this is actually not a proposed 2026 initiative. This would be something that's effective for the activities that you are doing now, meaning your current performance year. Again, since these are claims-based, you're not actively doing anything, but we have a couple this year in the proposed rule that impact how you are scored on your current activities for your 2025 performance. So just drawing attention to the fact that it's not all proposed as 2026. Some of them are current year. Essentially going forward, what they would do is set the median performance rate at a score that's derived from the performance threshold. And then, not unusual, the methodology is very consistent across the different activities where we have a scaling factor. It really is standard deviations applied for those scoring ranges. So just calling attention to it, not a lot that you can do other than be aware. And you'll see some changes perhaps in our final scoring should this all go through. They are also proposing some changes to the APP Plus quality measure set. Remember that this measure is optional for eligible clinicians, groups, and APM entities, but it is required for those that are participating in an MSSP. So specifically, the ACOs are required to report this measure set. If you're reporting it, all the measures in the set are required. And the MIPS quality, essentially what they're saying is if we make a change to the measures that are part of traditional MIPS, then the APP plus quality measure set will automatically be adjusted to align for that. So they don't have to do two separate statements or rulemaking related to that. So it really is just making sure that there's parity between those two. Measure under traditional will look the same as the measure under the APP plus, with the exception of under APP plus, it also is proposing again to remove that screening for social drivers of health, measure 487, that would be removed from the APP plus quality measure set that is not part of the traditional reporting option. So under cost, there are no proposed expansions or reductions to the existing inventory of those 35 cost measures that you're currently scored on, as appropriate based on case minimums and things like that. There is a proposed informational only feedback period of 2 years for any new cost measures before they impact scoring. So for example, if they put out today that there's going to be a new cost measure effective for performance year 2027, it would be 2027 in effect. It would be in effect for 2028. You would be getting feedback on those measures, but it wouldn't impact your score until performance year 2029, which means it wouldn't impact your payment for that 2-year lag. So it wouldn't hit your payment until payment year 2031. So I think really it's just trying to help providers understand when they put out those new cost measures, how to understand what they are, what those potential impacts are, how they're scoring, and to the extent that you have the ability to impact and influence the results, that you have time to do that before it impacts your score. They are also including just a proposed modification on the total per capita cost measure as outlined here. And really, if you look at it, it's focusing on the attribution of patients and excluding events initiated by an APP, an advanced care practitioner. If all the other non-advanced care practitioners within the group are excluded based on specialty exclusion criteria. So recall that APPs are not specialty specific designated, and so that creates some noise in trying to measure some of the impacts on the data and some of the overall scoring. And so this is an attempt, I think, to kind of align APPs, a way to kind of steer it so it more closely aligns with other providers in the group that do have those specialty designations. For the improvement activities category, there were 8 activities that were suspended on May the 6th of 2025. Again, this is another one of those situations where there were changes made in the current year. The suspension was made in the current year for performance year 2025. Clinicians are advised to select other improvement activities to complete in that announcement when they announced that suspension. But CMS did note that if a provider was already relying on a suspended activity and they had completed it, they were in the process of getting it completed, you can still attest using those suspended measures and receiving credit. But then you see, as we get down to our 8 removals, we're removing those suspended, so they won't be available going forward in 2026. So short takeaway, the suggestion is no longer to select those. If you were already relying on them, they're available for 2025, but they will be gone in the proposed rule for 2026. They also added 3 measures, and they made modifications to 7 different measures. They are also proposing the complete removal of achieving health equity subcategory and then adding advancing health and wellness. And so I think, again, you'll see that theme running through on those that are removing. And then you also see by the addition of the advancing health and wellness, CMS's continued focus on wellness care versus sick care, the chronic treatment, the treatment of chronic illnesses, those types of things. We continue to see that just they continue to navigate through that theme. One piece as we're talking through special statuses that here we're looking at small groups, those in HPSA, less than 15 providers, which will be impactful when we get to the MVP category as well. Whoops, new technology, let me go that way. So related to the promoting interoperability, they are proposing some modifications. And really where I see, if I were just characterizing it, they're looking for more information. There are certain attestations that you make when you submit for MIPS that are yes, no. And now they're asking for additional information. So for example, on the protecting patient health information objective, specifically related to the security risk analysis, before it was asking if you had reviewed and conducted an analysis. This year it's asking you the next layer down. That would be a yes. Now they're adding a second category that says, did you conduct a security risk assessment? And if you say no, then you get 0 points for the category. So they're kind of diving down those extra layers to get additional information as far as how far providers are going into each of these measures, where a yes, no may have been a gate. Now it's going down other levels. There's also information related to the higher priority practice safety assurance feature in the EHR. So really getting that safer guide measures, proposing requiring meeting the 2025 safer guidelines. Currently, previously it was referring to the 2016 guidelines. So getting those contemporary. A new optional bonus measure related to public health reporting using the TEFCA measure. You'll see as they get to the RFIs in particular, they're looking for additional information, trying to really encourage providers to report public health information, making that data reliable and therefore usable for other purposes. It also has they're proposing to allow a measure to be suppressed within the MIPS programs. Right now, there's not a way to suppress. It's either all in or out. And then they are also proposing the suppression of the electronic case reporting for performance year 2025, again, for the current year. This will be important if you've been impacted by the CDC's pausing of onboarding of new healthcare organizations within the electronic case reporting software and capabilities. So they're understanding the current environment that a lot of providers are in, the CDC changes. And so this one is proposing a suppression for that purpose. Back to MIPS value pathways, we talked about that a little bit. Again, their goal is to have, eventually to have 100% participation. They are continuing to push so that there are relevant pathways for at least 80% of eligible clinicians. And so you see here that they are adding 6 new proposed MVPs related to diagnostic radiology, interventional radiology, neuropsychology, pathology, podiatry, and vascular surgery. It's interesting to me which specialties they're able to quickly get these MVPs rolled out on. But that will give us 27 in total. We have the 6 new. We had modifications to the 21 that are currently finalized. So the six plus the 21 will get us to 27. Most of the changes in the 21 are alignment with proposals to update the quality measures and the improvement activities. So again, if they make a change in traditional MIPS, it'll automatically carry over to the MVPs. Some of the key notes related to the transitions, though, allowing groups to attest to specialty composition during registration, even single specialty groups. What does that mean specifically? Historically, CMS might have made, if a single specialty was all urology based on claims data, then CMS would have already just assigned that group to be urology. Now they're during the enrollment phase, the group would just click that they are urology. Their goal is to allow groups, including small groups, to really evaluate. They're trying again to remove those barriers so that they can evaluate their participation. Previously, it would have just been based on Part B claims, and it's not always clear which path those claims should go and how they should map groups to. It also allows multi-specialty small practices. So again, practices with 15 or fewer clinicians, allow them to continue to report as a group for performance. I say continue, they would be able to report in 2026, meaning it's optional, but they don't have to form subgroups. Before, in order to register, a multi-specialty group had to register at the subgroup level, the individual level, or the APM level. So if it's a tax ID that has less than 15 clinicians, they can register as a group and still perform that way. So giving those small groups a little bit of additional flexibility. You'll see here they're giving QCDRs and qualified registries a year to adopt a new MVP once an MVP is finalized, for them to get the time to get their processes in place, to get their systems updated in order to be fully supportive of that MVP. At one point, it had to be the same year. It's stretched and it's ebbed and flowed, so they are giving them now a year to get everything in place and running. I mentioned the RFIs. There are a number of areas. They do have we've got 7 RFIs related just to the quality payment program. So high level, they're looking for feedback on the core elements in an MVP, meaning those elements that go across all MVPs. Every MVP has 3 or 4 core elements. What's the quality of the information that they're asking for? Are there suggestions on others that would be better in order to provide, again, more meaningful information? The well-being and nutritional measures, they're looking for feedback on measures that measure well-being and nutrition and that can provide a comprehensive approach to disease prevention and health promotion, common theme that we're seeing. Asking about thoughts on using tools and measures that allow the use of codes, procedure codes, for MVP assignments. So are there procedure codes that we can then steer providers to this MVP versus this MVP, trying to help match, again, for comparable data so that we are making good comparisons? There are some FHIR-based ECQNs there. Again, I mentioned the transition to potential changes on the query of the PDMP, the Prescription Drug Monitoring Program. Currently, performance is yes or no. And again, they're asking for now that EMRs are more fluid in the use of PDMP, what are other things that could be queried? And how can we dive in to understand how deeply and how fluently providers are using that information? Again, looking for opportunities to have performance-based measures in the public health and clinical data exchange domain. And then related to data quality, are we getting good information? What's the quality data environment what's the current data looking like for providers? And how are we being able to exchange challenges that you're providing? So again, I encourage you to review those, chime in, and submit comments as appropriate for your environment. Martie, back to you, I think.
That's correct. Let's talk about the proposed ambulatory specialty model, which has its roots in the MIPS program, specifically the development of cost measures. And through the last decade, CMS has specifically developed a series of episode-based cost measures. And you see here on the screen those that are specific to chronic conditions. So these are rules that attribute beneficiaries that determine what services in or out of the episode for that chronic condition, and thus are able to compare how much does this physician cost to manage a condition versus that physician. And that is the genesis of this new mandatory alternative payment model that is set to start on January 1st of 2027. It will be mandatory for selected participants, individual physicians, as measured by the MPI-TIN combination. So there are 2 categories here: those specialists that manage lower back pain and those that manage congestive heart failure. And you see there on the screen which particular specialists this will impact as identified by CMS. You then have to be practicing in a selected location. CMS will determine those locations based on a stratified random selection of CBSAs and metropolitan divisions. They intend to include about 25% of all CBSAs and MDs. The third requirement is you have to have attributed at least 20 episodes of either low back pain or congestive heart failure. And that again is based on the criteria that is part of those episode-based cost measures, and how those are initiated to bring you inside. We are expecting a preliminary list of selected participants by the end of 2025, and CMS will then publish the final list of who's in and who's out for 2027 about this time next year. Methodology very quickly is that if you are an ASM participant, you are going to report on specified measures across 4 domains. Look very familiar, they're the same domains as MIPS. Your performance then is compared to benchmarks that are calculated exclusively on other ASM participants' performance. So in fact, we're going to have a pool of physicians and rank them on how they perform across these measures. And then your payments based on your position in that rank will be adjusted based on your performance for the 2027 performance year, 29 payment year. CMS expects those to range from a -9 up to a +9 on billings for professional services under the fee schedule. You will, I guess this is the good news, if you are an ASM participant, you'll be exempt from MIPS reporting requirements for any year in which you're selected. You see there the timeline CMS has proposed for this 5-year model. The quality measures, and again, no more selection out of the 109. These are the ones you will report on if you are an ASM participant, either for lower back pain or for congestive heart failure. On the improvement activities, you don't get a select from any of the large list. Instead, there are 2 specific improvement activities to which you will have to attest. Both would be equally weighted in the scoring. On promoting interoperability, very similar to what that you do for MIPS currently. You see there the specifications that CMS is proposing for the program. To get to the final score, then you will be assigned a number from 1 to 100 based on your quality and cost scores. And then you'll either get an adjustment of 0 or a negative adjustment based on your improvement activity and your promoting interoperability score. To that base score, CMS will then apply a complex patient score adjustment, as well as a solo or small practice scoring adjustment as well. And again, you line everybody up based on their score. You determine where the median is. Those people get the bonus. Those below get a negative. So it'll be very interesting to see how CMS continues to develop this alternative payment model. But this is the reason we pay attention to MIPS, is because we expect things to grow out of that program and turn now into new payment models. So this is so refinement down to data then that individual beneficiaries can make decisions about the physicians from whom they want to receive services.
And
finally, with regard,
I know you're trying one quick thing on that one, the +9 and the -9, on MIPS, it was budget neutral. So very few providers, once the exceptional performance went away, actually got to plus or minus. You had to do like nothing to get -9. Did they reference that on this? So there's no.
Yes, it's where you line up in the number. Yeah. You either win or lose. There are there's some neutral adjustments if there's certain gaps in your reporting that they'll make, but otherwise you're going to get lined up and assign the percentage you're going to receive.
And then I forgot to mention. Oh, go ahead.
Over time, they're going to increase that from 9%. They're saying beginning in 2028, it goes up 1% each year then. So we'll end up at 12%.
Yeah, it'll be interesting to see if it gets diluted, because I think that's what ultimately happened with MIPS because of that budget neutrality component. And then we had COVID, so there were some extenuating circumstances. The other thing mentioning too on MIPS, for a lot of our colleagues out there, they might be newer to MIPS, and I did want to remind folks that we did a MIPS 101 last year. It's available on our website. So if you need a refresher to the nuances of what we're talking about, it's available to you that way.
That's part of the reason, that when it went away, when it didn't seem as significant a change, people paid less attention. I think that's the intention here with CMS is pay attention. We're going to compare you to your peers, and we're going to start with 25% of you, and we're going to grow this program out. I think is clearly their intention. This is what MIPS was meant to be. It took a decade, but here's where we are. With regard to the Medicare Shared Savings Program, very minor changes this year. They are summarized on the 2 slides. I'm sure you're totally capable of reading all that content on your own. So if you enjoyed today, Come back again on August 13th. We will do the rest of the Medicare Shared Savings Program. Oh, what did I just say? Rest of the Medicare Physician Fee Schedule provisions on that day. And then on August 27th, we will tackle the final inpatient PPS rule, which we anticipate being published here next week. We're all excited because that will mean episode 100 of our Healthcare Regulatory Roundup webinar series. Again, thank you all for joining us. We really appreciate you. Jennifer, back to you to take us home.
All right. Thanks to our presenters, Martie, Sarah, and Lori. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.